Okay. Hi, everybody. This is the Informed Dissent podcast. I'm here with Cori Cohn, Eliza Green, Jamie Reed. I'm Lisa Davis. And I've been waiting to say this for a long time, but it's been a quiet week in Lake Genderbegon. 40 cents to whoever gets that reference. So we are going to talk a little bit today we're going to talk about a new paper, but mostly about the questions the new paper raises. And in the future, we still plan to do more of some kind of a news roundup. And we're thinking maybe we'll have a detailed news list for paid subscribers. But as everybody knows, we are building this a little bit as we podcast it to mix a metaphor. So we're figuring it out. And if you want to give us feedback in the comments about what you'd like to see or hear from us, please do. Does anyone have anything they want to announce or say about their lives or worlds before we talk about this paper? Any news? Any
somebody's missing. Is that worthwhile?
Somebody's missing, right? That's why we all fit. Yeah, the fifth member of the fifth Beatle is finishing his book. So Ben should be back. He should be back next week, although
he should be back next week.
Yeah.
I think final edits are this week, right?
I thought he said the 12th. Yeah. This is fascinating for people. But anyway, he'll be back soon. He's finishing his book, Cis White Gay.
What a devastating way to start the new year, having to do book edits.
Unless that's fun for you.
I would like to just acknowledge I'm in a new physical space. This is my new office space. I have moved from the bedroom upstairs. Roxanne has officially moved out. We have been separated a long time, so we have been rearranging the house a bit. So I have this new space.
Well, cool. Congratulations.
Thank you, Lisa.
I just made that word up.
That's what writers do.
I'm in my office space that I think my husband is in like 90% of the time, but it has all my book covers in the background. So he's forced to talk about that. And it's covered in crap because one of us is a slob and the other is a minor slob. We'll let people guess who's who. Okay, so we'll do our recommendations at the end, but for now, let us discuss this paper. Gender affirming medical treatment for adolescents, a critical reflective on effective treatment outcomes.
So if you were just listening, though, effective is actually in quotes in the title of this paper.
Right.
Yeah, Cori was wanting one of these quote cards last week, and we really need it this week, so I'm just going to make one.
Okay. So this paper is by a bunch of clinicians, a bunch of Dutch clinicians. And in fact, in their positionality statement, they write, all authors are currently affiliated with the Center of Expertise on Gender Dysphoria in Amsterdam. The authors represent varying gender identities and sexual orientations, including trans, queer, and cis. Hey, which of those is a sexual orientation?
Yeah, I actually made a serious note about this. So I wrote, no one is gay or lesbian, but they're claiming, and they make the point to say those three, trans, queer, and cis.
Yeah. One of the authors has experience.
But DeVries is a lesbian.
Well, in this paper, she is referring, my assumption is she's referring to herself as queer.
Okay.
One of the authors, the person we're talking about now, I think has experience with assessing gender affirming medical treatment, GAMT, in the Netherlands. As a young, accessing.
Accessing.
Right. one of the authors, so in other words, one of the authors got medical treatment as a young adult. And another of the authors that we mentioned is Annalou de Vries. She is one of the founding mothers of the Dutch Protocol, and she is the lead author of two papers from 2011 and 2014 that basically are the evidence, quote unquote evidence, that spurred a lot of other countries to adopt the protocol of evaluating kids at the right time, putting them on right time at the appropriate time, the Tanner stage 2, putting them on blockers, and then almost all of them went on to hormones and surgeries. And these two papers are also the papers that then later are called out as being of questionable methodology and low certainty. So De Vries is kind of at the center of the debate, even though nobody really knows that. And it's even interesting that in this paper they call it gender affirming medical treatment, because that's really the American approach, which got rid of some of the assessments that the Dutch had pioneered. And De Vries has now kind of been put in the position of defending her research and defending the Dutch protocol. And we should say that many Americans and Canadians and other people were doing this with kids long before the 2011 and the 2014 papers she wrote. But those were, I think, I don't know if you'd all agree, those were the real justifications. Like, now we had it in writing. We put, we started with over 100 kids. We put 70, we evaluated 70 of them, and then 55 by the last paper. And there's a lot that could be said about those papers, but there's a lot that has been said. But along the way, there have been a series of changes and approaches, including going from treating just gender dysphoria, trying to alleviate gender dysphoria in young people, and trying to predict for whom medical transition might be the appropriate or best way to do that. And what it is now, which is affirming a gender identity and helping people realize their authentic selves, which are excavated, this internal thing excavated through external interventions. And so that's a little bit of a little mini background on De Vries, on how it started. And now we're at where it's going. We're at, 10 years later, 10, 15 years later, and we're no longer treating just gender dysphoria. And even though we keep hearing that gender affirming care is safe, effective, and life-saving from advocacy groups, we see when people evaluate the actual science, when they conduct evidence reviews, that none of those claims can be backed up. And here arrives this paper, which Jamie is going to outline for us. That is a kind of way for them to reframe this conversation and to ask a bunch of questions, I guess, so that they can answer them in the way that they'd want.
Perfect. So the first thing I do want to just point out for those listening is this is an open access research paper, which means you can actually Google this yourself if you would like to read it. It's about 20 pages long. It is not super dense in terms of, reading medical research literature, because it's not.
It's super dense in a different way.
It is. It's super dense in a different way, but I think, having read a ton of papers like this, I feel like this is accessible in ways that if you want to try to engage in the work yourself, please do so. I want to just go over a little bit about who they are and what they did. So there are 5 listed authors on the paper. Lisa's already given us a really good kind of overview. They're all from the Netherlands. These are all clinicians. What they did, methodologically speaking, I'm going to read the first line from the methods section. Using trans negativity as a theoretical lens, we conducted a theory-informed reflexive thematic analysis of the literature cited in the research evidence section of the SOC 8 adolescent chapter. So they went to WPATH SOC 8 and they pulled out 16 articles that are listed in their research evidence section. There were 24 total, they pulled 16. They then, all of the authors, it appears, then read those 16 papers and they started looking for their own themes, the things that they themselves, it stuck out to them as the theme of these 16 papers. And then this happens a lot. What they started to do is they coded those themes. So what basically you start to do when you do coding is you create buckets and you throw either quotes in or in, elements of the paper into those buckets, and you start having different authors see, do you have the same buckets? Do you fill the same buckets in the same way? What buckets are most important? And then they kind of analyze these papers based on the themes that they coded out of their reads of these papers. So this is 16 papers that they don't even go into whether or not, are these the same papers that Cass reviews? Are these the same papers? Or, it's not really a deep dive into what those papers are. This is more about the themes that come up in these papers. They then code and claim that there were 4 major themes that came up out of these papers. The first theme, and there's 1, 2, 3, 4. Okay. So theme 1 is doing bad, experiencing distress before gender access for medical treatment. So this theme is capturing the suffering of trans youth due to gender dysphoria. So then they pull out all of the things that they feel like falls in that bucket. Then second theme is moving towards a static gender identity and binary presentation. Throw everything in there that fits in that bucket. Theme 3 is, are they doing better? Is there overall improvement? And then the last theme is the absence of regret. So they then dig deep into these 4 themes. Then they explain kind of what they felt like these themes were representing, and everything keeps going back to what they refer to as this trans negativity theoretical lens. I will be honest, the first time I read this, I normally highlight in red, yellow, green. Red is most problematic, yellow is maybe okay, and green is, something that's interesting, sticks out. The first red I used was that phrase, trans negativity is a theoretical lens, and I wrote, what the hell is trans negativity? So conceptually, they then point to, basically, we end up somehow with Andrea Chu and Florence Ashley. And
who those people are for familiar?
Cori, do you want to say who those people are?
Sure, I can at least hit Andrea Chu.
Yes, please.
Who is a Pulitzer Prize winning critical literary writer. I think that's a fair description. Who writes for the journal +1? Is that it? Not
N+1.
It's N+1. Thank you.
But yeah, there's +1, the academic,
Right. N+1.
but also writes for New York Magazine and I don't know, other big outlets.
And a very memorable op-ed for the New York Times.
My Vagina Will Not Make Me Happy, I think was the name of it. So I think
Well,
this,
that's where I was going. That's where I was going.
Yeah.
Because I thought that this was actually a very insightful op-ed when it was presented. and it was saying, even though this might have caused me to have health complications, even though it might not make me happy at all, I deserve to have it. I deserve a chance to try. And this is probably like there's no argument here except I want it. And it's sort of honest. It's honest because and even visionary, because this is where everything is going.
And
that really is choose function in this world, is to say all of the quiet parts out loud, even if
Right.
people really don't want him to do that.
And they quote directly in this paper, they mention trans scholars argue that the experience of gender affirming medical treatment are often messier, more ambivalent, and temporarily more complex than the binary of doing bad before and doing better after. For example, Chu notes, quote, I feel demonstrably worse since I started hormones, and mentions increased suicidal ideation after gender affirming medical treatment. Despite feeling worse during her transition, Chu states, transition doesn't have to make me happy for me to want it. And this is the conclusion, essentially, of this entire endeavor, which is the evidence does not support the narrative that someone was in pain, distress, we give an intervention, they get better. That this is no longer the through line for transition care. Instead, it is personal desire and autonomy. If I want it, I should get it.
Yeah, I think as Eliza said, this paper is all about saying the quiet parts out loud, and it's also, I mean, it's an interesting paper because it is acknowledging all of the things that we've been bringing up for the past couple of years, and it talks about the lack of evidence, the lack in both in quantity and quality. It talks about, they say that they're treating distress, but they don't ever define what distress is. So even the diagnosis is so hazy, that there aren't outcome studies, that we don't know what the goal of the treatment is. We don't know if puberty blockers are a pause button or an on-ramp to treatment. We don't know how to measure its success or failure. We don't know if regret is a good thing to measure, or do people have the right to regret? So it brings up all that stuff that we've all said, like, yes, this is what we should be talking about. And it even says when kids go in for treatment, they should be told that no one can tell them if this will make them better. And in a way, this is what I've argued for, is to say all that stuff, because I thought if you knew that there was no good evidence, if you knew that no one can tell you, that if you can no longer say this is evidence-based, safe, effective, life-saving, I feel like people would make different decisions. But it's really interesting that this paper finally acknowledges these arguments that no one would acknowledge. They would just kept saying evidence-based and life-saving. And still they come to the conclusion that the treatment shouldn't make you feel better. That what is the point of the treatment if it is not so that you feel better and to function better? It's almost like saying, functioning well is such a kind of like Western bourgeois, etc. Why do you want that? We should have the right to be low functioning. And it's really a meeting of postmodernism and science. I mean, it's really like we are letting a literary critic decide the medical path for young people. I mean, does she have a PhD? Maybe she's really a doctor, or he. Sorry, I'm pronoun confused. But that's what I think is so it's very brazen and a kind of last ditch attempt to salvage, I think. I don't know if it's brazen or desperate or both.
I think it's brazen. No, go ahead, Jamie.
No, say more, Eliza. You
Yeah,
think
you say more, Eliza.
Okay. Well, I was going to say the explicit aim of the paper that the authors state up front is to challenge binary restrictive narratives about transition, such as a narrative that, doctors were treating a medical condition and the patient got better. The really interesting thing is that they still, at the end of this paper, want to call it medicine. But it's pretty obvious that their main goal is they want to show that these treatments benefit patients. They want to find a set of outcomes that they can measure or point to that can show that the treatment benefits patients even when it harms them, basically. And they are explicit that gender-affirming medical treatment can, what do they say at one point? It's like that gender-affirming medical treatment can make it worse, can make patients worse. And then we'll talk about the kind of pervasive logics of improvement and the need for nuanced and an interdisciplinary perspective on what we might otherwise call a negative outcome. Jamie, you mentioned the focus on lack of regret as one of the themes of the papers that the authors reviewed. And they really do come out and say, like, okay, if we consider lack of regret a positive outcome, like that really suggests that the presence of regret would be a negative outcome. And we don't like that because that might stand in the way of teenagers accessing interventions that they might later regret. It's a really surreal paper in a lot of ways, and it really is a good summary of where the field is at the moment. I went to the WPATH conference in Lisbon online a couple of months ago, and Annalie DeVries spoke there. She gave a talk exactly along these lines in which she said things like, maybe we even don't regret it as a provider if people detransition. And she says, should patients improve? I'm not totally convinced of that. And she said things like, we all know that this is important, but why is it important? And it is really illustrating the place that this field is, which is it is under siege from external critics in a way that has never been before. And at the same time, it is needing to relocate as this embattled fortress to higher ground because the foundations are sinking into the moat. And that is a very delicate thing to try to do. And Lisa or Jamie, one of you mentioned the right to regret. That was also a heavily featured argument at WPATH that just a really surreal session about the dignity of risk and the right to regret that compared teenagers having double mastectomies to saying something that you regret at a party and thinking about it at 2 a.m. for years. There's this complete denial that there is another way to look at this, which is, okay, you're a medical provider. You still say that you're providing a medical treatment and you have a responsibility to appropriately evaluate and treat patients. They really want to just completely, if they can make everything about patient autonomy, if they can put everything on patients, if the patients have a right to regret the decisions that the patients make, the role of the clinicians can disappear. And that is what they want and need as their field comes under attack and as they personally have to live with themselves, I think.
What do you all think about that phrase of it's better to regret what you have done than what you haven't done? I mean, I feel like they're drawing on that, which certainly is something that was said to me by a married man when I was 21. So anyway, I regretted that more than he did. I mean, does that just is there any merit to that? And even if there was, would it apply to the patient population we're talking about?
I think that's a good question, but I wanted to insert an observation here, which is that for any of these types of interventions, we should be able to ask the question, why are we doing it?
Mm-hmm.
And receive a reasonable, persuasive, hopefully evidence-backed reply. This tactic or the strategy is to obliviate the why question completely.
Yes.
So that anybody who asks why, you get turned around and told, why are you asking why? As though asking why is somehow transphobic, right? Trans negative. That's the whole strategy here, is to make it offensive to ask why we would transition anybody, particularly young people. It's devilish.
Yeah, it's why, well, the patient wants it right now, and they are positioning themselves to deal with the field's emerging problems and really to co-opt those emerging problems of detransition and regret by saying, well, we fulfilled an adolescent's potentially temporary and foreseeably regrettable embodiment goals, and if those embodiment goals, they like words like fluctuate or are fluid in the future, we are best positioned to help them realize their new embodiment goals, and that there is no judgment attached to changing the body, and that there is no other, and we've seen this in some studies, like the study of the teenage girls getting mastectomies, was the measurement of success was, does the patient have breasts anymore? When she didn't want them, and then we asked her like 6 months or a year later.
As we say in the software world, it's not a bug, it's an unplanned feature.
Right.
Well, I think these observations are really interesting, and I have two things I want to say. One, to Cori, to Cori's point, I think what this paper does is first of all, it's talking about WPATH SOC 8, and for those not in the rabbit hole, that stands for the 8th version of standards of care from the advocacy group WPATH, which appointed itself the world expert, and they took almost 10 years to put out the 8th version of their guidelines. But as some people know, when we unearthed information from the various bans and lawsuits against the bans, we found that SOC 8 had a fundamental lie in it about adolescents, which is that it said there wasn't enough evidence for them to do a systematic review. And that turned out not to be true. They had done a review via Johns Hopkins. They had suppressed it. Even the federal government, the HHS, knew that they had suppressed it. And there was really what should have been a giant medical scandal that's mostly been ignored around the very document that they are critiquing as being wrong-headed because it's looking too much at whether people did better after treatment. So it's almost like saying, yeah, we agree SOC 8 is problematic. Not for the reasons, that came out in the lawsuits, but because it prizes being functional and healthy. And we don't think that's an appropriate way to measure the success of a treatment.
No, we think it's binary and normative, healthy, unhealthy, good, bad.
But the embodiment goal part is kind of interesting because Jamie and I were just talking to someone who said some detransitioners are worried about insurance companies covering detransition care because then it's actually more work for those same surgeons and doctors who hurt them. So there's a young woman who got a double mastectomy and now is getting breasts, quote unquote, is getting implants from the same surgeon who removed her actual breasts. And there's a worry about just like a lot of people are already going to be permanent medical patients, but not wanting to keep filling the pockets of these people benefiting from preying on these people in distress. So, and I think if we're going to be honest about it being embodiment goals, if they're going to say, yeah, there's no evidence for it, and acknowledge all of the criticisms, then why would it be paid for? Or why would we have trainings about it? Why would we start teaching kids about it starting in preschool? If it's just embodiment goals, either you're going to pay for my tummy tuck too, and a little liposuction or whatever because I'm physically uncomfortable now, and it's this. Why is it any different? If it's just like I want to look how I want to look, why is it any different? Although maybe someone would say, why are you banning it then? Because we don't ban rhinoplasty for teen girls.
But we don't pay for it.
Right, we don't call it medicine. We call it cosmetic surgery.
Well, what if that's the outcome?
Yeah, I mean, it seems like
Cosmetic.
that's a logical conclusion from what they're arguing, and yet they still want it to be considered medicine and their work to be respected and for it to be reimbursed. I think that's going to be a tough needle to thread because they really are saying the wish to be transformed by medical technology now suffices, and the treatment, by definition of being provided, is a success because it answers what the patient wants right now.
Can I
Or
go
should we
back
say customer?
20 minutes?
Yes.
Okay. So Lisa, you said that part of what you would like to see is if this paper represents the kind of truth about what they're doing, you want patients to be informed of that, right?
Yeah, that there's no evidence that this will make them feel better, that there's no one can tell if they'll regret or not, that it sometimes makes people worse.
If are you kind of saying if that was what was laid out to the patient and they go to the gender clinic and that's how it's described, do you think the outcome would be a decrease in patients agreeing to this?
I think so. I think a lot of, at least with parents, I think they're very concerned with suicide and they believe that this is evidence-based and life-saving. And this is acknowledging that those claims are not true. If you brought your kid in and your kid is saying like, I'm gonna kill myself if I don't transition, and then the doctor says, look, actually, we don't know the rate of detransition, we don't know the rate of regret, nobody knows what we're treating, there's no agreement about anything, and nobody knows if this will help or hurt. What would you do
As a parent?
as a parent? And these changes are, a lot of them are permanent, and you may, what would any of you do? what
I
what
think I have a slightly different take on that.
Good. Let's hear it.
So in order to provide medical consent, so the parent, the patient, for anyone to be able to ethically consent for a treatment, there's a required series of steps that a doctor has to lay out. I mean, this is what's supposed to be documented in your chart. You are providing consent, or the child is providing assent. The first step is a diagnosis.
Mhm.
So I just keep feeling like this paper is not only removing this from the realm of medicine, just, in the wider lens, but it's removing it from the realm of medicine and even the ability for someone to consent to it. So if I cannot tell you a diagnosis, if the quote diagnosis is this is what you just want, then it's not medicine. Because if step one in consent is diagnosis and then the nature of the procedure, then the risks and the benefits, then the reasonable alternatives, then the risks and the benefits of the alternatives, and then the doctor's supposed to assess if a patient understands all of that. So if you cannot teach back or show the clinician that you understand that there is no diagnosis, that this is purely you want something,
Mhm.
like I just don't see how any of this can continue to function.
Well, what if it was treated as any other kind of cosmetic intervention? That I would feel better if I could walk around without a bra, if you did something to my boobs, and you didn't pay for it, and they told me here are the risks, and there's a risk with any surgery and the anesthesia, and it's a difficult recovery, and can't tell you that you might still not need a bra. I think I mean, you might still need a bra. I think I would not do it because I'm scared of those things. So maybe I'm not the right person, but I wonder if would you allow people to do it if it was treated like any other cosmetic intervention? Or is it impossible because
Are there other cosmetic intervention? I guess my question then becomes, what other cosmetic interventions are signing up for lifelong medications?
Well, I think if you get a breast reduction, you probably can't breastfeed after because they remove your nipples, right?
Well, they remove and reattach them.
They attach them, but they don't work.
But again, that is a one time you go into surgery. I mean, we're talking about a quote, there's some element to that. This is not cosmetic because it's not just I'm tweaking something and then you go on about your day and there might be some, long term. This is like, I'm going to give you a sustained drug. I'm going to give you hormones for this extended period.
But you can go
Yeah,
off
we're going to.
hormones, right?
You can do what?
You can go off the hormones.
Well, not if you've had your gonads removed. You
say, right. You have to take some, right, but that's fairly rare. So for what if it was no, you can't remove gonads, but you can do all the other stuff. Thought experiment.
Why?
Again,
Why are you doing? Yeah, why
are you doing?
Why?
Why do you get a nose job or a boob job? Because you want it. You want it to. Oh, you want to feel better. You want to feel better, I guess. Why do people?
I mean, one of the most.
Yeah, go ahead.
Oh no, finish your thought. I was
No.
going to change the topic just a little.
Yeah, change it. Do it.
Oh, okay. Well, I was going to say one of the really interesting things about the paper was they acknowledge in a couple of places that patients believe in these more global improvements in, that their lives will be improved, their mental health will be improved. And I wanted to say just a little bit about that from my research on the online communities, and I'd love to hear from Jamie, like her experience meeting with patients and families and what kind of expectations they were bringing into those consultations, because I think that that's a really important background too. And I would say what I see all the time in the online communities is, yeah, patients do have these, what I would describe as really unrealistic expectations for what are effectively cosmetic, but also damaging interventions. And they also really in the management of questions and doubts about transition and whether it was a good idea and whether it's working, will really cling to, I was assessed, I was diagnosed with gender dysphoria. This is a medical treatment. These are these rosary beads that these kids are, going to for consolation when they're like, I think I'm feeling worse. All of the most common storylines that I see online, which is I feel worse with every step of transition, or I thought this would help, and now I really need this other surgery that I didn't want before because maybe that'll help. I think that is a really important context for the changeover that the leaders of the field are proposing, that is detaching it even more from what patients, because patients don't just want their embodiment goals fulfilled.
You think that they actually do want to feel better?
They want to feel better, and and in many cases, I mean, a lot of these kids have an unrealistic understanding of sex and gender, and they want things that you can never reliably get through surgery, like to be perceived as a member of the opposite sex by everybody that you interact with, or to become a member of the opposite sex, or to not, have questions and doubts about identity all of the time, and to just be able to like start living your life.
I will say from working in the clinic,
Mhm.
we did see the getting worse. We did see the kids getting worse. Um, I don't have good data to say was it more with puberty blockade than with cross-sex hormones or with feminizing hormones versus masculinizing hormones. But there absolutely was a significant cohort of patients who we started on a medical intervention and then they plummeted, that it was
Yeah.
mental health was worse. Overall functioning was worse. They did say that they felt worse. They would tell us they felt more suicidal. Chew is not an outlier in that. I think there's a whole subset of people who start these interventions who do feel worse. The issue, again, coming back to, is this medicine, is in really any other kind of treatment protocol that I had worked with. If let me try to come up with a real basic one. If I give someone a first line antibiotic for an ear infection and they come back and they still have the infection, I'm going to stop that intervention and try something else. I'm going to go to a second line, or I'm going to increase the dose, or I'm going to change the protocol, or I'm going to make a medical change because the medical outcome that I was seeking is not what's occurring. And that's a real basic idea. But I mean, like, you're treating cancer, you're treating, these pervasive, difficult medical interventions. There often are times where you stop the treatment if it is not providing the outcome that you desire. And one of the things I really struggled with was when the patients would come back. I'm thinking of patients specifically on pubertal blockade where we started them and then they were totally tanking and their parents were fretting. Like they're supposed to be getting better. And, they went from some suicidal thoughts to suicide attempts. And never once did the clinician say, we need to stop this intervention. It's clearly not having the intended outcome of what we wanted it to do. And that to me was, again, a dereliction of basic medical principles. The intervention itself sometimes clearly can harm, and you stop it. People can be allergic to things. People can have negative outcomes to interventions, and you stop the intervention. And in gender treatment, that never occurred.
Oh, go ahead, Cori.
Aren't there some mythologies about the risk of stopping?
Oh, yeah, absolutely. I mean, we would get, yes, there's so many, that's the other thing. There's so many myths out there, and I think that the quote trans community is correct in that a lot of this, they've been given bad medical care. And there is a lot of figuring out on their own and doing things like that. But we would get calls from kids who would be on vacation and they're gonna miss their dose of testosterone from a day, and they honestly think that they're about to have a heart attack or a stroke. And we're like, dude, no, you can, like, the endocrinologist is like, you could just stop this at any time. There's no, you're not, this is actually not a life-saving intervention. You just stop it.
Well, but some of the influencers on the trans side would describe that as a forcible detransition, or they might describe it as life-saving care that is being withheld.
Mhm.
They might say that if you stop taking estrogen, you'll become suicidal.
I actually would love to have an in-depth conversation about what a forcible detransition is. I have tried to discuss this nuance on Twitter before and fell flat because if the concept of the transition is that you are read by society as the sex with which you were trying to pass as, if you're on testosterone for 15 years and have had top surgery, you don't need to take testosterone again. You will, you know what I mean? Like some of these things, it's what is detransition actually mean? I can't force you to, even if we stop giving you testosterone, you can still live as a passing male.
Well, maybe the people who tend to raise this objection are male and not living as male.
The trans women.
You mean the people who need to continue to take it in order to reach their embodiment goals?
But they don't. But that's the thing. So
It's
many of these
just,
things are irreversible that it's not. It's not. They will claim that it's the hormone that's affecting their brain in some way. That's like it not. I've never met an endocrinologist that believed that.
that believe that taking cross-sex hormones reduces suicidality. Is that
Uh,
what you're saying? Or
I'm
what
saying,
else?
I, I think that they never explained it in such an extreme, like, oh, if you miss estrogen by a month, your entire brain is gonna like shut down and it, there's just a lot of there was a lot of dramatic conversations from patients about the intervention where the endocrinologists really kind of saw this as meh, you chose to do this, you can choose to stop at any time.
Well, I also feel like that's part of this kind of informed consent I'm talking about, which is one of the things that I feel like when whenever I'm talking to people in my world whose kids have transitioned, there is never a we can try this, just try it out and see how it feels. And if you don't like it, we won't do it. There's always a we're making these huge changes. I remember, I feel like I talked about this already, but I remember hearing Sasha Ayad talk about like if we held this lightly, and if we still had that room for the cognitive dissonance of, like when you call drag queens girl, and you know what you're doing, you're saying it and not exactly meaning it, and we could handle that ambiguity and dissonance, and we still knew what was real. It was before we were asked to affirm a lie about changing sex. uh so I'm just thinking about, you know if it was treated like any other adolescent phase, as
But
for the
it can't be a
social
phase because the doctors cannot, they know they're giving you.
not
But
the medical transition. The medical transition can't be treated that way. But
Lisa, you brought up this really great example of this. So in the center where I worked in St. Louis, there was this parent group that was directly tied. So if you think about Tavistock, you know that there's a parent group that really was pushing them along. We had a similar parent group. It was the parent group that actually pushed the center to be open in the first place. However, this parent group would run a monthly parent support group where the parents would come in one room and then all the kids would go play in the gender, I don't remember the phrase, like gender exploratory daycare space. And then they all were making buttons about their pronouns and wearing princess crowns or whatever. Um, there was a parent who was running, it was a group of parents who would run each session and they would take turns. One of the parents' kids desisted. Young kid, prepubescent, desisted. I thought this is the best parent to continue to run and be in this group. And from, like every 3 months, this parent would show up and run the session and would say, hi, my name's blah, blah, blah. My kid's desisted. That parent was pushed out. There was no room in that parent group for that parent's narrative or that child's narrative to exist. They couldn't be a part of it anymore. And those were the things cognitively where I'm working there going, but wait a minute. Why can't desisted? This is a great example of how incongruence can become like
right.
that cognitively didn't line up for me.
You know what's sort of dark about that, though, Jamie, is that these parents also have social needs and they're depending on each other to affirm their decisions about their kids. And these other adults are about the only ones that are safe to talk to about what their kids are going through. So if your child desists, then you are excluded from your social group. You lose your friendships.
Yeah, I
Darn
think
kids.
that this is a really interesting example because, I'm sure we've all heard Hakim, the British psychiatrist, talking about how he would run these groups, these gender dysphoria support groups, and there were people wanting to transition and people who had transitioned. And very few people transitioned after talking to the people who had transitioned because it didn't seem to be a better life. And I'm not sure that would work today because I feel like people who have transitioned, Cori aside, don't feel like they can say no, this isn't good, right? Because you also lose your community if you're involved in that community and do it. And I also think there's been such a big shift in parenting. I think I know for me that there are a few things I wish someone had said to me that would have really changed the way I parented when my kids were young. One of them was, their pain is not your pain. And I still have trouble with this. Like my 12-year-old was just exhausted and falling apart the other day. And I just am telling myself, like, don't get mad, don't lose your cool. Like, it's going on forever. We're going over the same stuff. She doesn't want to feel better right now. I keep saying, like, have a glass of water and let's just calm down and let's take a little walk. And she was saying, this is going to come back around to the paper, but she's very smart. And she was saying, why can't I just feel bad right now? Why you're the one who needs me to feel better. And of course I did, because she's coming to me with the problem, but I have never learned how to separate my pain from her pain. But I have tried to teach my kids that it's okay to feel bad sometimes and just to go through it and feel it. I think that's different than, like, I'm exhausted and hungry and I'm not taking care of myself and I'm having a meltdown. But, when bad things happen and there's grief and sadness and anger, and just, instead of telling them you shouldn't feel bad, saying, like, it's perfectly fine to feel bad, go ahead and you'll get on the other side of it. What I think is interesting about this paper is that it is, in a way, sending that message, a message that most kids today don't hear. Most kids today are learning that if you feel bad, it's someone else's fault. And everyone has to treat you in a way so that you never feel bad. You must be included all the time, unless your kid desists, and then you're out. And any kind of uncomfortable, negative feeling, there's been a lot of air quotes but anyway, is a problem that has to be solved. So I think it's just like a lot of kids who detransition eventually get to the kind of radical acceptance they needed to get to before. This is making a good point, which is, it's normal to feel bad, except it's saying it's normal to feel bad after you've gone through incredibly radical medical interventions that are permanent. And Cori looks like he has a reaction. Just here. Anyway, that's a lot of thoughts in one, but I do think that I'm from this generation of parents that not only can't separate my pain from my kids' pain, but thinks pain is a problem that must be fixed no matter what.
Are we that helicopter parent generation where
Snowplow.
Snowplow. Okay.
Snowplow is worse. Snowplow is,
I've never heard that one. Clearing all the obstacles?
Right.
Yeah.
Right.
Okay.
clearing all the obstacles so that your kids don't have to work hard and try hard and feel defeat when they can't get over them, and then they never learn to navigate the obstacles. No, I see some skepticism. I welcome
No,
your.
no, no, no. I'm thinking of, you're talking about kids, and you said, you kind of brought it back to this paper. And I'm trying to understand why did DeVries and these authors, do they not see kids as being in kind of a different protective bubble than adults? So I still see Andrea Chu has I have a different ethical dilemma with an adult potentially making a decision where they are going to choose something that they want to feel that's going to make them feel bad for the rest of their life. And I still ethically feel that Andrew Chu has a little bit more leeway to make that decision. And I'm not saying that I think doctors should be providing that. I'm just saying the ethical decision. I kept reading this thinking, are they actually still talking about kids? Because isn't this a way different leap for a kid to be asked about their personal desire and autonomy decision and their embodiment goal as a kid than as an adult?
But they are constantly erasing that line. I mean, Joanna Olson Kennedy, she'll talk about, she'll be asked about 2-year-olds and she'll call them people. Like they're always erasing this like developmental stage and age considerations and acting like these what we think are certainly distinct patient populations are the same, that we can project backward. Like the whole idea was to be able to project backwards from a trans-identified adult to a child who is an appropriate target of puberty suppression, even when they acknowledged that they didn't know how to figure out which of the kids they were seeing would become the adults whose trajectories they wanted to change.
Well,
And
they
there's this,
conclude, yeah, but they conclude this paper saying a promising approach would be through participatory action research, which involves transgender youth.
yes,
So again, it's like centering the child to make the decisions in a way that I just don't, children cannot make those kind of decisions.
yeah, but that is exactly what like the session about the dignity of risk and the right to regret was about, children and adolescents. And what DeVries said at WPATH was about children and adolescents. And the push for participatory research was, well, what do the teenagers want out of it? And ideally, it's something where we could show that we had provided it, no matter how they might feel about it later.
I just think we live in this bizarre world where we're talking about children making decisions about lifelong medical interventions. And we also have 20-somethings into their 30s who cannot get out of the nest and take on a job and buy a house. Like childhood has become this thing that lasts until forever, yet we're putting on 13-year-olds medical decisions.
Yeah. It's this adultification of actual children and infantilization of actual adults.
Ooh.
At the same time.
Star
And
I said, star that quote. That's a good one.
yeah.
Or you
But
something you wanted to interject?
I was going to say that reacting to something that Jamie just said about the medicalization of children, and I'm not sure that that's the frame that they use. I think that they think that the medicalization is just ancillary to the other goal, which is self-realization, and that the medicalization is just a side effect of becoming your true authentic self.
It's just
So
is, of course, the project of adolescence. Yeah.
And adulthood.
Yeah, I think you're right, Cori. They really, I mean, it's just another example of how they are reducing their role and trying to shed their responsibilities by, they're just facilitating the realization of a young person's emergence as their true self.
Right.
And I guess shifting the risk off themselves if they're just
Oh,
facilitating.
absolutely. Yeah.
And then
Oh,
if your gender identity changes, it's not our fault. Your identity changed, and we're still here to help you realize match those things up. Except at a certain point, you can't. But I do, yeah. It's like medically assisted adulthood. Sorry, Cori, you were going to say.
well, I just wanted to maybe propose another why question, which is why do the authors of this paper feel like this is an argument that needs to be made? Why are they putting their names to these ideas? Why are they doing it? They obviously have an objective they're trying to achieve. And maybe it's a personal objective, which is that they're trying to develop a reputation or notoriety or advance their careers. That's one possibility. The other is that they have an ideology and that they're trying to affect some sort of change in the world. Maybe it's a combination of these two things, but why do you write a paper saying that children should be able to medically change their sex, even if there's no evidence that it's an effective, that it leads to better outcomes? Like, why are they doing it?
I think that they are slightly transparent in that in this paper. I mean, they know that they are, I think back to the castle metaphor, they know they're under siege.
Mhm.
They know, and they basically call out that that everything that they have built is under attack, and they almost say under good attack. Like they almost like agree, like, yeah, maybe we have really kind of jacked this up, but we didn't really, but we're gonna spin it in such a way that we didn't. But they are saying in here like, they point to the American laws, they point to international criticisms. Like in some
Mhm.
ways, this paper was, I don't know if it's like true, but I feel like in some ways this paper was like, we see you, Segum and like every single, institution that's been coming after us. We see you. We know you're coming after us. Yes, fine. We see you have cannons and they're pretty well stacked, but we're gonna change the goalpost.
I I see it as trying to control the conversation that that they are acknowledging every objection that's been levied. They acknowledge, something that people were refusing to acknowledge for a long time, which is what's happening in a lot of other European countries, which is more similar to Republican bans than not. They're not the same thing, but they come from the same place, and some of them are effectively the same thing, like in a small country. So where one person holds the keys to the whole kingdom. So I think it's a way of it's like steering into a skid, right? To get control. But
Yeah.
I also think I would call it the Judith Butler defense, which is just to string a lot of words together to kind of confuse people, to have the argument be so, back to that word brazen, since Eliza endorsed the word, that people say yes, because it's actually hard to formulate an argument against it because it's so out there. And it reminds me, I can't remember if I talked about this before, but I have this friend whose boyfriend has this very annoying habit of talking gibberish nonsense, but throwing in a bunch of $10 words. So he might say, when I went to see the Falcon and it was a heteronormative, cumulonimbus, etc. And I've seen people nodding along, thinking they're getting, oh yeah, I see what you mean.
Mhm.
I just think like, what did I just think it's mean and horrible and condescending. But I also see how people just fall in line and they think I feel like I should know what he's talking about, so I'm going to say yes. So that is the butler defense, because her early work was, so it was really opaque, and it was hard for most people, including me, to get through. I just gave up. So that might be, these are different ways of trying to win. And they're trying to win both so they can keep doing it, but ultimately it's got to be to indemnify themselves too, just like the parents, right, who transition.
There's an interesting little passage in here though, where I do think when you're talking about they're trying to control the narrative and the language, I think they're doing a little thing here where, first of all, they say it's the visibility of more trans individuals it's the visibility first and the scrutiny second. So there's so many more. It's just because trans people are more visible now that you're bringing on this scrutiny. I wrote in the margin, is it the visibility of trans people, or is it that there's actually bad care with bad outcomes? What comes first? But then the following sentence is, in the United States, an increasing number of anti-trans bills, blah, 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 blah. These limitations are increasingly paralleled in Europe. They're putting the US first, the anti-trans bad bills in the US as happening first in the timeline, and that Europe is just paralleling the US. And I think that that's intentional because, first of all, they're in the Netherlands. For them to have reversed that and say, well, actually, all of our compatriots in the countries directly surrounding us have recognized first that this was a really bad idea. I think that there's an intentional, again, switch of that narrative that this is just bad politicalization coming from the US. Again, it has nothing to do with the outcomes being poor or what is the actual intervention doing. It's back to this is just being anti-trans people.
That was a good catch. I didn't catch that they were saying that it came from the US to those countries when actually those Finland and Sweden were quite way before. I mean, they caught on before us, and
they're saying US anti-trans bills, and then they list Sweden, and then they list the NHS in England. I mean, it's like, no, come on, like they know better.
They're seeing what's going to happen. They see the inevitable.
Well, but they're also, aren't they kind of saying they're going to hold on till
they're trying to pull a switcheroo where it's like, okay, this was never about anything other than transforming the body. They kind of suggest, it's almost like they don't know where patients got the idea that there might be bigger improvements. And it's kind of problematic that patients think there'll be, broader improvements. And they're going to say, if access to transition is about patient autonomy, patient values and preferences, if it's a human right to self-expression, then it cannot be withheld even if patients are harmed, even if they regret it, even if they detransition. Like that is the way that they're dealing with the harm, the regret, and the detransition becoming more visible, is to say it's just completely beside the point.
Well, I'm afraid I'm going to have to wrap up here.
Okay.
All right. It's the end of your lunch hour. All right. Do you have we'll stay on just a couple more minutes, but Cori, do you have a non-gender recommendation for the week?
Not really. And I'll catch up with you next time too. I don't want to interrupt the flow here.
Okay. Okay. We'll see you next time.
Thank you. I'll talk to you later. Bye.
Okay. So should we let's wrap up this paper and let's go back to the ultimate question underneath it, which is, what are we treating and how do we know if it worked? How do we get people to see that we can't answer either of those questions? And
that's the $1 million question, Lisa. How do you explain a paper like this to the basic normative Democrat that was elected in the state of Minnesota? That is going to continue with this narrative. This is evidence-based life-saving care.
Even
When the creator, one of the
When the creator
creators
is like, never mind.
I mean, like, how do you get
yeah.
Yeah.
that's where the frustration is yeah.
But I
Yeah,
don't.
yeah.
Oh, go ahead, Eliza. Go.
Oh, I was just gonna say the leaders in the field are moving the battleground to more favorable territory of patient autonomy, whatever, right to regret. But like Jamie's saying, yeah, most of the foot soldiers are gonna stay on the it's life-saving. If you don't support this, you want these kids to be dead. Like there isn't going to be a recognition that that ground has been ceded by the people who initiated this treatment model.
I'm thinking about. I don't know where this book is. I'm thinking about the Dutch Approach book, which is
Oh yeah.
Yeah, the Alex Bakker book.
Yeah,
yeah.
great book. We should definitely, well, link it in the show notes, but then explain you have to change what country you are in Amazon
Like buy it from Germany.
if you want to
To
pay
buy from Germany.
$200 for the book.
Yeah,
But-
it's very expensive, but it was really illuminating, and it helps you see how De Vries and the other Dutch clinicians who pioneered these treatments, how they changed and a little bit why, because we do know that patients had to lie to get what they wanted. So there were patients who didn't want their penis removed. There were patients who did not want to be actually pass as women or live as, they wanted to change their bodies. There actually were people all kinds of in between. So as much as we may dismiss the notion of non-binary, the truth is that once you get into, especially, autogynephilia and the different kinds of autogynephilia and different ways that people fantasize about themselves, once they could be honest, it was very, very different from, if I don't get this, I'm going to kill myself, which is what they felt they had to say in order to get what they wanted. So in some ways, this paper may reflect the reality, which is that as opposed to having actual gender dysphoria, Jamie's leaving, that they
Leaving very excitedly.
I mean, you started, Eliza, by saying that they're saying the quiet part out loud, but yeah, they are. They are saying, I just want this. And they used to lie to get the doctors to give them what they wanted. And they're saying,
Yeah, I mean, there is a expression of a wider range of desires for body modification. I guess my main takeaway from the book is that as much as there is this attempt to revise history now and to say it was just about changing the body, so why did you expect, why should patients get better? Like what De Vries has said very explicitly in now multiple forums. But one of the things the book is really explicit about is that this was seen, the decision to offer transition at a Christian hospital, Christian University Hospital, was an act of mercy to alleviate suffering.
yeah.
And now that the evidence has not come in, and we have no idea what other evidence the Dutch clinic is sitting on, there are things that have been presented, researchers thought behind closed doors at WPATH that have never been published, that are very concerning out of that clinic. We don't know what they're sitting on, but they're completely pretending now that there was never any intention to improve generally. They're just completely rewriting history. And it is definitely because of what they know about what they have done. Because
But
the patients are doing better.
But even in that book,
everywhere.
the only ethical reason that they gave, they state in the book, we recognize that we are harming healthy bodies.
Yes, we are harming the health. Like they said, we need to redefine what healthy is.
Right. They're saying we know that this is that ethical line you're not supposed to cross. But they're saying
the patients really want us to.
The only reason why we're going to cross it is because there's such immense suffering that we have to be compassionate and alleviate it.
Right.
Mhm. And they really do say like you have to have a strong stomach to
Do this.
see it that way, like to do this. Yeah.
It's almost like it's the poisoned penis defense. That they were saying, yeah, these body parts are healthy, but if they cause this much pain and distress, are they really healthy?
That's the poisoned penis defense.
I
I
just
had
made it up.
never, okay, I was going to say, I had never heard the poison penis
I'm,
defense.
I'm making up a lot of defenses, but there the goal was clear. Yeah, as Eliza said, the goal was to ease suffering, and therefore, if you caused more suffering, which
Mhm.
in some ways it could be argued that the adults who transitioned, they were at least still suffering. It was unclear if they were suffering
I
more.
mean, there's a guy who says in the book that he's seen the harm that transition could cause dozens and dozens and dozens of times.
They were so explicit in that book.
And in a way that's this paper is doing too. It's funny,
Yeah.
the Dutch are known for being so straightforward, so I don't know. Maybe this is just their brand, but I guess the takeaway is that people should really be looking for this goalpost moving and
Yeah.
really pay attention to how the language, the goal changes. And ultimately, when we talk about evidence-based medicine, when, I've heard Genia Abruzzese talk about this, that if there is no good evidence and if there is no medical consensus, that what we revert to is patient preferences, values and preferences.
And the
And
fight just cannot end up there. It cannot, it has to be about medical
but there is
responsibility.
always still a question, even in values and preferences, there's still a societal ethical question about what we pay for.
And about what doctors can ethically provide.
Exactly. So then we come back to, can a doctor ethically do that? And do we pay for it? And who is paying for it? And
Yeah.
I don't see the societal push that I have to pay for anyone else's values and preferences.
Yeah.
In a
And I
joint
think,
insurance pool, in a Medicaid, Medicare situation, I think it's a strong societal question for values and preferences in that way. And I definitely don't see it for children.
yeah. Yeah. And we cannot let the debate get stuck on values and preferences. It's
yeah,
just completely beside the point.
that's a great tip, Eliza. Don't let it be about values and preferences. Make it about medical responsibility. And this paper is a complete abdication of medical.
It's just a complete erasure of the concept. Like, where is the clinician in this paper? The clinician is not in this paper. The
Yeah,
when DeVries talks about her work, the clinician is not in that work.
that's not true. It's Dr. Andrea Long Chu.
Oh gosh.
Not a clinic. Okay.
Okay. So okay, let's wrap it up. I think we've solved all the problems. This has been informed dissent. And we are going to end with our non-gender recommendations of the week, because I don't know if you guys heard this. There is a world beyond this topic.
Where you have been visiting.
Well, that's true. Yes. I recommend I have something more affordable than a safari to recommend. But Jamie, what's your non-gender recommendation?
A home milk warmer frother. Very inexpensive. I got an espresso machine for Christmas that I adore, and I purchased a small milk frother to go with it. And I am trying to kick my Starbucks habit in 2025.
Okay. Is that what you just got so excited about 10 minutes ago?
No, I got so excited 10 minutes ago because my 16-year-old finally passed his driver's test.
Okay. Did he show up at the door and just go like?
He just showed up at the top of the stairs. This was his third attempt, and he was like, and I was like,
okay.
And he goes, you shushed me and I finally passed? Yeah.
Okay, well, congratulations.
And Eliza, you're
oh my God, I'm trying desperately to think of anything. I have been reading Saki's The Unrest Cure, which is illustrated by Edward Gorey, and it's hilarious. And it is none of the problems. It's a great read, when you're stressed out because you will never have any of those problems. These are upper class turn of the century problems. And they're great.
What are some of the upper class turn of the century problems?
Disagreeing about dressing for dinner with someone who turns out to be dead.
Hmm.
That's never happened to me, but
Hmm.
I've never dressed for dinner.
We'll have to dress for dinner someday and
Oh
then
yeah.
don't
I
be dead.
don't know if
Yeah.
I want to until I reach my embodiment goals. Um, my recommendation, I have a lot of recommendations. I've been enjoying some things lately, shockingly, but this one is not is sort of about gender. And it's for females only. But no, it's not really about gender. It's just you can talk about gender there. I was just going to recommend Megan Down's Unspeakeasy community. And
Okay.
for people whose goal in 2025 is to speak more freely or find more community outside of um, whatever culture they've been living in, um, I recommend that. It's been important to me, and you can talk about things other than gender there. Um, so, all right, I have some more things for next.
Okay. Oh, you're gonna save
No,
them? You
no,
don't think you're
I'm gonna save them because I might not do anything in the next week that doesn't have to do with gender. When I look at my schedule,
We're gonna have some strange bedfellows time next week.
we are,
Okay.
but we're not.
We're not previewing it?
We're not going there.
Okay.
This is, we'll discuss if well, I guess I could have just pretended I didn't know what she was talking about. Well, on that cryptic note, thank you for the people who are still watching, and please give us feedback. We're new at this, so tell us how we're doing and what you and tell us some more of your recommendations for non-gender life too. We'll
For
see.
non-gender life and recommendations for things you want us to talk about.
Yep. Okay.
Okay.
See you two and everybody else very soon.
Okay.
Bye.